Veronica, Mercedes. Fatima, can we start or do it with already? I can see participants joining, so I need your advice.
I think we should start.
Nancy, yeah, that's what I want to ask.
Okay.
Start.
Bonjour tout le monde. Hi everybody.
Hi.
So I'm Triphonie Nkurunziza. I'm the team lead for the reproductive, maternal health and healthy aging in the WHO regional office. I will be introducing and moderating this session today. I'm very pleased to see the participants joining. This is the second webinar on the new Partograph. It's really my distinct pleasure to be with you, with all of you today. We have convened the second webinar together with WHO, UNICEF, and UNFPA in collaboration with the World Continuing Education Alliance. And we're pleased to really have the opportunity today to present the WHO Labor Care Guide, which is also known as the WHO Next Generation Partograph. We'll do all we can so that the new Partograph is accepted, is understood by all the users. Colleague, as you know, the death of a woman during pregnancy, childbirth, and the postnatal period continue to be a major problem in the region. We know that sub-Saharan Africa accounts for 2/3 of globally recorded maternal death. And as we stand now, the projections are suggesting that at the current annual reduction rates of 2.9%, Africa may not meet the SDG target for maternal mortality reduction of 70 per 100 live births by 2030. This calls all of us for focused and accelerated action by country so that our region can reach the SDG target in only 10 or even 9 years. So we also know that it's so important to improve the quality of care around the time of birth. Evidence shows that this is the most effective strategy to reduce maternal and perinatal mortality, and we can have triple return on investment. So a key aspect of intrapartum care is monitoring of labor, previously done using the Partograph. And as you all know, in 2018, WHO launched the intrapartum care recommendation for a positive childbirth experience with updated labor monitoring guidance based on available evidence. Subsequently, a new labor monitoring tool was developed to align with the updated recommendation for intrapartum care. This new tool, known as the WHO Labor Care Guide, together with its user manual, was launched on 15 December 2020. So today we're having the second webinar, and really we urge you to pay careful attention to the explanation provided and to study the document that will be given to you from this webinar. We also encourage you to disseminate the information learned through all possible forums so that your peers and other health workers who did not have the opportunity to attend this webinar have a clear understanding of the new labor care guide. For those of you who are lecturers, professors, master trainers, we urge you to review your curricula and content to ensure that this tool is part of the pre and in-service training. I want to finish my welcome remark by really thanking all of you to take your time to attend this workshop. I also want to thank really our panelists who are led by Dr. Mercedes Bonet from WHO headquarters in Geneva. I want to thank the World Continuing Education Alliance that has provided this platform for this webinar. I really want to thank also the organizing team that is comprised of Fatima Goa from UNICEF SRO and Muna Abdullah from UNFPA and Nancy Kidula from the WHO Intercountry Support from the ESA region, and for all who have facilitated the preparation of this webinar. We are also gathered here because we have received some grants from the Swedish government through the Together for SRH initiatives that enable us to provide joint support as the together with WHO, WHO, UNICEF, and UNFPA. And the panelists of today, we do have three eminent panelists who are led by Dr. Mercedes Bonet. Mercedes is a perinatal health epidemiologist who is based in the Department of Sexual and Reproductive Health in Switzerland. You will see her, she has extensive experience in global health with a focus on improving the health and well-being of women and newborn through research and development of evidence-based recommendations. She also works on maternal infection and sepsis. She will be leading the team made of Dr. Veronica Pingray, who is a midwife and epidemiologist at the Institute for Clinical Effectiveness and Health Policy in Buenos Aires, Argentina. Her research focused primarily on maternal and perinatal health, with a special emphasis on postpartum hemorrhage, stillbirth, intrapartum care, and the use of cesarean section. She was part of the team coordinating research study and the project evaluation to develop the labor care guidelines in its user manual. The team is also with Rose Laisser, who is a senior lecturer in midwifery and women's health from the Archbishop Anthony Mayala School of Nursing, Catholic University of Health and Health Science, Mwanza in Tanzania. Rose Laisser coordinated the team that piloted the labor care guides in Tanzania. So, colleague, distinguished participants, we have a 2-hour session, some with the support of Nancy, Muna, and Fatima. So maybe I should also we look through the agenda so that you know how the session will be processed. So can some present the agenda, or do I have to present the agenda?
Triphonie, you need to present the agenda. Would you like me to project it for you? Okay, I think Fatima has projected. Just proceed.
Okay, so, okay. Do you see, are you seeing my screen? Oh, okay. Fatima, wonderful. Okay, good morning. That's good. So the first, I think the first part of the agenda is already finished. It was me, I'm going to present the agenda. So as you can see, we'll have some remarks from Hilma Shikwambi from the International Confederation of Midwives Africa. Then, because we have learned from the first, the key point from the first webinar, which was done on February 25th. And then we'll have a 45 minutes really to go in depth on how to use the WHO labor care guide. This will be led by Veronica, Pingray, and Rose Laisser. And then we'll have a 20-minute on questions and clarification that will be led by Fatima Gohar. And then this will be followed by a 15-minute presentation by Mercedes on the labor care guide in comparison to the previous WHO modified Partograph. We also have an overview of additional resources. So this is done because the first webinar, there were several questions asking what was the real difference between the Partograph and the new ones. So, and then I hope everything will be clear, and then we'll have some 20 minutes for questions and clarification, which will be led by Muna Abdullah, and Nancy will give the next steps in only 5 minutes, and we will have the closure of the webinar by me. So without saying much, I want to give the floor to Hilma to give her remarks. Welcome, Hilma, and the floor is yours.
Thank you, Triphonie. I hope everyone can hear me.
Yes,
okay. Good mornings and good afternoon, everyone. Always a great pleasure connecting with Midwife, especially in our great region, the Anglo-African region. As Triphonie has said, my name is Hilma Shikwambi. I am a midwife by profession, and I'm based in Windhoek, Namibia. I am a board member of the International Confederation of Midwives, where I present Anglophone Africa. One thing I'm positive about is that I'm sure the majority of us joining today through the invitations, hopefully sent by the midwifery associations within our countries, and also all the other platforms that were enabling the midwives to join this very important webinar. This being the second session, one thing we should appreciate is that, you know, we all would want to sort of maintain our continuous professional development, because without that, our care will not be as evident. This WHO labor care guide, we know it aims to support good quality evidence-based respectful care during labor, childbirth, irrespective of where women find themselves. While this webinar at the same time is enabling us as midwives, especially us who are at the bedside, to successfully use this labor care guide, and also to offer, as I've said, what is called the evidence-based care. So it's really a privilege that we are part of this session today. And one thing I would like to highlight is the challenges that we are all facing, brought on by the COVID-19 pandemic. We have to appreciate the innovations that has brought actually a positive impact, because in my normal life, normally an invitation like this will take 3 months before it reaches me. but now it's reaching us just at our palm of our hands. And I'm seeing right now over 600 participants are watching. So really innovations that are brought forth and they are enabling us to connect and also learn as the evidence is coming by. I would like to appreciate the WHO, UNICEF, UNFPA, and WCA for their investment in midwives. I recently read an article, I think Mercedes was part of the authors, where actually there is evidence that with a substantial increase in coverage of midwives, if we are delivering our intervention within our scope of practice, we could avert about 41% of maternal deaths, 39% of neonatal deaths, and 26% of stillbirths. That's actually a great findings. And as Triphonie has said, actually, if we would want to achieve our SDGs, we need to invest in quality care. I'm looking forward to the interaction during this session. It's a pity I didn't attend the previous one, but I'm sure I will learn a lot. I've heard of many positive feedbacks coming from the previous session and really looking forward. And thank you, Triphonie.
Thank you very much, Hilma, for really those encouraging words. I'm now pleased to give the floor to Dr. Mercedes Bonet, who will give a recap of the key points from the first webinar, so that at least those who were not there can really have an idea of what was discussed. So Mercedes, the floor is yours.
Thanks, Triphonie, and good morning or good afternoon to all of you, and thanks for joining again. It's really a pleasure to be here, and thanks also to those who were not able to join the first part of this webinar but are with us today. So as Triphonie said, we will start with a recap on what we presented on the first part of this webinar, and try to answer some of the questions that you had. And I saw already that there are questions around what is the evidence underpinning the changes, and can we have access to that evidence? So you will see through the webinar, we will try to give you that information. Unfortunately, we don't have time to go into details, but we are happy to take some questions, and we make sure that we have enough time for that throughout the webinar. So the structure of the webinar today is pretty similar to the first part. So I will quickly show you the objective and then have this summary of what the labor care guide is and how, when you can use it. In the first part of the webinar, we managed to go through the first four sections of the LCG. So today, Veronica and Rose will focus on section 5, that is where you can plot labor progress. Section 6, which is the one around medications, and section 7, that is the one where you can record your plan and the shared decision-making process that is that will take place as you follow up women through labor and care for them. I will then close giving that comparison with the previous WHO modified Partograph and provide you with some additional links and resources that we have. So the review of key points from part 1 is to start with. Then on the second objective is to understand how to fill out sections 5, 6, and 7, identify similarities and differences between the labor care guide and the WHO modified Partograph, and then provide you with additional resources, as I said before. So some of the slides you will realize that are the same that we used last time, but we really thought that it was important just to go through this again, especially also for those who were not able to join the first time. So why we work on the labor care guide and develop it. So the main reason is that after the publication in 2018 of the WHO recommendations on intrapartum care for a positive childbirth experience, and I'm sure that you at least have seen the document, have read it, and we initiated this process of revise the previous Partograph, and this was mainly for two reasons. And both of them will help us to effectively implement the recommendations that are in that document. So the first reason is that there's this global, very important shift towards improving experience of care and providing women with that positive childbirth experience. So things around expanding the focus from only labor monitoring to those non-clinical practices that promote that positive childbirth experience was very important to us. And this is reflected, as you now know, in this second section of the labor care guide, where you can monitor and then add around supportive care measures. And the other reason is that there's new understanding on how labor progression varied across women, and we needed to take in account that. And major changes were introduced in this section, and we will have the opportunity to discuss this further later on with Veronica and Rose around labor progress. Although the reasoning behind it is the same, the limits that we now know are more evidence-based in terms of how we define labor and how quickly women progress are different. And I will expand a little more on that. So the labor care guide has different aims. It will help you to guide and the monitoring and the documentation of your assessment for the well-being of the woman and her baby, as well as labor progress. As I mentioned it before, it would also help you to provide supportive care throughout labor to ensure that women have a positive childbirth experience. It was also designed in a way that will help you identify early on any deviation from normality, not only in terms of labor progression, but also all the other clinical or non-clinical parameters. With the whole idea that this will prevent unnecessary use of interventions, such as, for example, augmentation of labor or cesarean section. And finally, with these new sections around care plan and shared decision making, it will support audit and quality improvement and will help you and your hospital to follow up what is happening and being able to act on that and improve the care that you're providing to women. So briefly, for whom, when, and where shall you use the labor care guide? This tool was designed for all pregnant women in labor, and this is regardless of their risk status. However, you might remember from last time that we noted that women who had some risk factors might need, for example, more frequent monitoring, or might need a different type of care, and this has to be also considered. When is the time to open a labor care guide? So as for the WHO Partograph, this is during the active phase of first stage of labor. However, based on the new WHO definitions of active phase of first stage of labor, this will be from 5 centimeters or more cervical dilatation, and this is independent of herparity or whether membranes are ruptured or not. It will allow you to provide continuous monitoring and support throughout that active phase of first stage of labor, and it also includes a second stage of labor part, and it can be used at all levels of care in health facilities, although the plan of action or the need of referral may vary depending on the level of and the resources in the facilities where you are working. We had last time a lot of questions around these new definitions of latent active first stage of labor. So we thought that it was good to just go through them again and make sure that you all know them. And I also saw that in the chat box, people were asking about the sources of evidence. So at the end of my presentation, I will put the links to the different publications that we have that supported the recommendations, so you can have them on hand. In the 2018 WHO recommendations, then we have a definition of active first stage of labor, defined as a period of time that is characterized by regular painful uterine contractions and cervical effacement and a more rapid cervical dilatation from 5 centimeters onto full dilatation, 10 centimeters for first labors and for multiples women too. And this recommendation is mainly based on a systematic review that we did, looking at how women progress from 1 centimeter to the other, and how long it takes them to move, for example, from 3 to 4 centimeters or to 6, from 6 to 7 centimeters, and all this looking only at women who at the end had good perinatal outcomes, both for them and their babies. And this review included over 30 studies and 200,000 women overall. And what we saw is that it's only after 5 centimeters that labor seems to really accelerate, and is very, the duration varies a lot before those 5 centimeters, and therefore the change in the definition. There were a lot of questions last time also about what to do during latent first stage of labor. I just wanted to flag that guideline document also includes a recommendation around policies to admit women to labor ward. And what the recommendation says is that for healthy pregnant women presenting in spontaneous labor, a policy of delaying labor ward admission until active first stage is only recommended if you are doing, for example, a study. But we are not recommended at this point for you to change your policies around delaying labor admission. And this is basically because there was no evidence that we could use to look at the benefits or the risks of delaying that admission in labor ward to the dilatation. And the document also provides some guidance in this sense, and says that women presenting to facilities in labor should be admitted and supported as appropriate, even when they are in this latent phase of labor, unless her preference, for example, is to await for active labor at home, and that they need to be monitored. And this is something that we also stressed last time. So it is not because she's in latent phase that there's no need to monitor and to follow up her well-being and the well-being of her baby. And this is until they are admitted into labor ward, where you will be using the LCG, and then monitoring becomes more intense in terms of frequency and the parameters that you will monitor, both for the woman and the baby. So for those who were not here last time, but also as a reminder for those who were able to join, this slide shows the labor care guide. And I wanted to go through the different sections and components of the LCG. So you can see it at once. So it has 7 sections. The first one up here serves to identify the woman, the labor characteristics at admission to the labor ward. This section 2 is around supportive care and includes monitoring of companion, pain relief, oral fluids, and postures. So whether the woman is mobile during labor. Section 3 is about well-being of the baby, and you can see the variables that have to be monitored are similar to those that were included in the previous Partograph: fetal heart rate, amniotic fluid, fetal position, caput and molding. Section 4 is about the well-being of the woman, and again, very similar to what you do in your current practice now, monitoring vital signs, pulse, blood pressure, temperature, and if possible, urine. Today, we will cover the last 3 sections. Section 5 on labor progress, Section 6 on medications, and Section 7 on shared decision making. Also to note is that the labor care guide includes an alert column, and this is across all the sections from Section 2 to Section 5. And this alert column provides some guidance on when to consider an observation abnormal and requiring a plan of action either to correct that abnormality or to manage it. And on this slide, I'm showing you a completed LCG. So you can see that healthcare providers should record observations once the woman enters active phase of first stage of labor, so after 5 centimeters of dilatation, and that there's a time axis and where you can follow up that woman and plot the different findings from your clinical examination and your assessment of the non-clinical parameters. Something to highlight is that includes, as the previous Partograph, the active first stage of labor, but also includes a section that allows you to follow up and record your findings for the second stage. So a time axis, an alert line, as I mentioned before, and a second stage column. When we publish the LCG, we also publish a user's manual, and this has been facilitated by the organizer. So you should have the links, and let us know if you don't, so we can put them again on the chat box. We would like to ask you to have it on hand and open if possible, because Veronica and Rose will be referring to the manual as they explain you the remaining sections of the LCG. And we think that it will help you just to familiarize also with the manual. So I will stop here and then pass over to Veronica and Rose to take you through how to complete the LCG, and then we will have time to respond to your questions. Thank you.
Thank you, Mercedes. Well, it's a great pleasure to have the opportunity to be with you again. And as you know by now, with the labor care guide, we are including in our routine care the monitoring of the same clinical parameters that we have always monitored, plus other non-clinical ones, those that can substantially modify women's childbirth experience. In addition, we are trying to avoid unnecessary, harmful, and sometimes even costly practices. So it's really valuable that we are together in this journey. Let's resume with section 5, labor progress. The next one, please. Yes. So here, this is just to remind what we reviewed in the previous session. We have different steps that we might want to follow to make the labor and childbirth monitoring regular and systematic throughout the labor. And we propose to start with the assessment. We have the first column with a list of parameters that we want to assess regularly. Then we have the first blank column where we are planning to record the observations of each individual woman. The second column, that would be the third step, is mainly to check the reference thresholds. And here, some will help us reminders, some other will help us to make some initial decisions. So it's always good after recording the observation to check how we are doing compared to the threshold. And finally, when we complete the assessment of the maternal and the fetal well-being, we will record a plan at the bottom of the labor care guide. The next one. So as we mentioned before, we have some guidance for you that we hope it might help to complete the LCG. So in the user manual, you will find many charts, and there's one chart per section. And we'll try to describe some suggestions on how to make the assessment of each variable within the section, then how to record it, which are the alert values or the thresholds, and a rationale behind the threshold, and finally, which would be the following steps depending on what we have observed and recorded. So we will keep on using these 4 steps throughout the completion of the labor care guide. The next one. Yes, so let's resume with section 5. This is labor progress. And this section is directly related to the recommendations below. We will review them now. And I would say that although all sections of the labor care guide are important, this section has some major revisions and important changes in relation to cervical dilatation thresholds. So this is a particularly important section of the labor care guide. And probably to fully understand the reasons for this change, it is essential to know in detail the recommendations for intrapartum care published in 2018. So if you are not familiar with the recommendations, we leave here below the link to access and review them. There you will find, in detail all the evidence supporting these new thresholds. So the first recommendation is that for women with spontaneous labor onset, the cervical dilatation rate threshold of 1 centimeter per hour during the active first stage is inaccurate to identify women at risk of adverse birth outcomes, and therefore is not recommended. It is interesting that for many years, some countries have stopped using the alert line because they did not find it clinically useful. In some settings, the Partograph are completed as more like as an administrative step or retrospectively, precisely because of this lack of utility with the alert line. Today, this hypothesis was confirmed with scientific evidence. And for that reason, the recommendation on the alert line was changed in 2018. We have several scientific publications evaluating the association between the duration of labor and the risk of developing adverse perinatal outcomes, and a low predictive value for the alert line was identified. Some other recommendations that are relevant for this section are that labor may not naturally accelerate until a cervical dilatation threshold of 5 centimeters, that women should be informed that the duration of active first stage, that is from 5 centimeters until full cervical dilatation, usually does not extend beyond 12 hours in first labors and 10 hours in subsequent labors. And finally, that women should be informed that in first labors, childbirth, the second stage of labor, is usually completed within 3 hours, whereas in subsequent labors, birth usually is completed in 2 hours. All these recommendations are key to understand the rationale behind Section 5 thresholds, and I would really encourage you to review it, the recommendation if possible. The next one, please. Okay, so Section 5 aims to encourage the systematic practice of the intermittent monitoring of labor progression. And labor progress is recorded on the labor care guide by the regular observation of 4 variables. That is the frequency and duration of contractions, the cervical dilatation, and the descent of the baby head. So let's try to identify these parameters in the graph. I know it's quite small, but if you have the LCG or the user manual, it will be very useful for you to review it at this point. So we have the parameters we will monitor in the first column. Then there we have contractions, duration of contractions. Then we can see cervical dilatation. And for cervical dilatation, we should plot an X to record the cervical dilatation. For the descent of the fetal head, we will plot an O. And then in the second column, we will find the thresholds. And we can see that the alert should be triggered when the lag time for the current cervical dilatation is exceeding these times with no progress. So this is the major change. If all the parameters remain normal, the fetal and the maternal parameters, it is not recommended to intervene with the fixed rate of the alert time. We can now use these new parameters that will give us more time, but we can wait during a longer period of time before administrating any intervention to either accelerate or change the course of labor. The following one, yes. So let's check how the user's manual suggests completing this section. If we go to page 18, we will find the chart with each of the variables of section 5. And as you can expect now, the charts indicate how to complete the SEG following these 4 steps. Here we are showing the first 2 variables that are both related to the uterine activity, frequency and duration of contractions, which are actually quite similar to the previous partograph. Then you can see it's quite tiny, I'm sorry, but here we have assess, record, then check the thresholds, and finally step 4, we can find the frequency of monitoring suggesting for each of these parameters. So there's a clarification that I need to make here. For contractions, the experts that developed WHO recommendations agree that contractions should be monitored every 30 minutes during the first stage and every 5 minutes during the second stage. This is also in the WHO recommendations report if you want to review it in detail. And you will see that there's no way to record that frequency during the second stage in the LCT. If we have to record it every 5 minutes. So given that there's no enough space to record contractions every 5 minutes during the second stage, the most clinically significant value within that 15 minutes time frame is the one that should be recorded. So for example, the longest contraction or the shortest, depending on each clinical case, is the one that we would want to record there and probably to base our plan to that observation. Then the previous one back. Yes, here, because this is, we split it in 2. We have 4 variables. These are the 2 second variables of section 5. And these 2 parameters are cervical dilatation and fetal descent. And this is probably, you know, a very important piece within this section. First, we will start recording cervical dilatation starting at 5 centimeters instead of 4. And second, as we mentioned before, the alert column thresholds no longer follow the 1 centimeter per hour. That is a fixed rate that was used in previous partograph. So today, we know that minimum cervical dilatation rate of 1 centimeter per hour throughout the active first stage is unrealistically fast for some women. And then that's why it's not recommended, mainly, you know, to identify if the labor progression was normal or abnormal. And non-fixed new cervical dilatation thresholds are proposed. So in this chart that is in the user manual, we can see all the details, the usual steps, how to assess, how to record, the list of all the thresholds for cervical dilatation with a short explanation to clarify how to proceed. And then we have the last step that are some suggestions on how to continue, what would be the next steps in case of different scenarios, if the cervical dilatation indicates a normal progress or a slow progress of labor. So let's see how to complete this section that is fairly, complicated for most of us. But let's see how we can complete it with an example, and this hopefully will clarify some of your questions. Rose?
Yeah, thank you, Veronica.
Okay, thank you.
So welcome all participants and thank you for joining. I'm going to lead you to an example of how to complete section 5. As we can see, there are some differences with our usual partograph, as what Veronica has said. Now, this example talks of Mary Jane. On the date, June 7, 2020, at 6 a.m., this was the time of admission when Mary Jane presented with 3 uterine contractions every 10 minutes of moderate intensity and lasting for 40 seconds. Her vag examination shows 5 centimeter dilatation, cephalic presentation, and fetal descent of 4/5. Given that all other clinical parameters are normal and that Mary Jane is coping with the labor, the midwife assessed the number and duration of contraction hourly, as our usual practice. Unnecessary vaginal examinations are avoided here, and vaginal examinations are only performed after 4 hours. Now, from 6 a.m. to 10 a.m., let's see Mary Jane. Mary Jane at this time complains of strong pains. Her sister, who is a companion, left the labor ward and Mary Jane is alone. Lying in bed in a supine position, her vitals are heart rate 96 beats per minute, blood pressure 128/84 millimoles of mercury, and fetal heart rate is 151 beats per minute with variable decelerations. Mary Jane has 3 strong uterine contractions in 10 minutes, lasting 50 seconds each. Fetal descent is 3/5. Cervical dilatation for Mary Jane is 8 centimeters now, not from 6 to 10 a.m. And the fetal position is occiput transverse. Amniotic fluid shows meconium 1+. Now, next slide, we are going to see what we are supposed to note and maybe plot in our labor care guide. You have seen that from the example, on admission, we have highlighted 3 uterine contractions every 10 minutes. And it's of moderate intensity, and they lasted 40 seconds. You can see a highlight of 5 centimeters, which now is active phase, if you remember the definition of active phase. Cephalic presentation of fetal descent, we also highlight the fetal descent of 4/5. So at this hour, we can note that given that other parameters are normal, we won't highlight. We go to 10 a.m. now. What we highlighted, we see Mary Jane has 3 strong contractions in 10 minutes, which were lasting less than a second, 50 seconds each. So fetal descent, we highlight it as it's 3/5, it has improved. Now cervical dilatation of 8, and these highlights are the ones which we are going, as you can see on the partograph, plotted on the active phase, 10 centimeter. Can you show? Can we highlight Mercedes? Yes. We can see our X at 10 And then our X, 8 centimeter, 2.5 hour, as we highlighted, and 5 centimeter in the beginning, more or less after 6 hours. When we check the descent, we are informed that you plot 0. You can see the parameters are plotted on the descent. As previously explained, this part, importantly, is about cervical dilatation and descent. Thank you. When you go to the second stage, we see Mary Jane with strong contractions there, and the descent is plotted at that hour, which were 10, lasting 50 seconds, and you can see the fetal descent 3/5, where the cervical dilatation was 8. Okay. So as midwives, this is how we are going to plot. This is just an example, but with practice, this is how we are going to plot according to individual women presentations. Next slide. At 13 hours, those were at 10 hours. Now at 13 hours, Mary Jane maintains 3 contractions in 10 minutes, and they maintain lasting 50 seconds each. We could see now the cervical dilatation of 10 centimeter. Can we show the, yes, 10 centimeter cervical dilatation at 13 hours. At 13:30, we are finding childbirth takes vaginally at 13:45. See second stage column, 13:45, childbirth occurs. Okay. Now we are having our baby this time, but the plotting is plotted on the parameters which highlights the important items for midwives to take action later. Thank you. Now, let us get some practice with a few questions. You are going to vote after selecting 1 or 2 on this question. Do the alert column value for cervical dilatation represent a fixed rate of cervical dilatation? That means 1 centimeter per hour during the active phase stage of labor. You can vote for yes or no. I give people some minutes to vote or to choose the best answer.
Thank you to all of you that are participating. It's very interesting to see your responses, and will help us to clarify some concepts if needed. We will give 15 more seconds, and we will close the poll and review this question together. The last 5 seconds, and okay, we are closing the poll. Okay. So here, this is a major change, and it's completely understandable that can create some confusion. So we used the alert line for many years, decades, and that was a fixed rate of cervical dilatation, 1 centimeter per hour. And actually, the new thresholds that are proposed within the labor care guide won't follow this rate, won't follow a fixed rate. It will, the amount of time that we can wait from 1 centimeter to another will be different depending on the different cervical dilatation that we are observing. So we are not following a fixed rate any longer. Those alert values or thresholds for cervical dilatation that we will see in the second column of the LCG will follow a non-fixed cervical dilatation rate. So the correct answer is no. So for pregnant women with spontaneous labor onsets, the cervical dilatation rate thresholds of 1 centimeter per hour during active first stage is inaccurate. It won't help us to identify women at risk of adverse outcomes, and therefore it is not recommended for its use any longer. We will follow a non-fixed cervical dilatation thresholds that are proposed in the labor care guide in the second column, and that are actually based on the most recent evidence. So thank you for participating. We will have another poll after we review the last few sections. So let's move to section 6. This is medication. And this section is directly related to the following recommendations for intrapartum care. So these are the key WHO recommendations for section 6. And that's that pharmacological pain relief is recommended according to women's preference, and that the use of oxytocin, antispasmodic agents, and intravenous fluids with the purpose of preventing labor delays is not recommended. The next one. So this section was designed to facilitate the consistent recording of all types of medication that we use during labor and childbirth. And we will describe mainly if the woman is receiving oxytocin or not, if yes, what was the dose, but also whether she was receiving some other medications. This could be pharmacological pain relief, antibiotics, corticosteroids, any other medication that we need to describe here. And also if she was receiving IV fluids, or if IV fluids were administered to her. So this section is not so different compared to the previous Partograph. But probably the very relevant piece of information here is related to these two recommendations. And we are trying to avoid medication during labor and childbirth unless it's clinically indicated, and also to administrate pharmacological pain relief if that's the woman's preference. So those are two key pieces of information when taking care of when assisting women and offering or making decisions regarding medication. Okay, so on page 18 in the user's manual, we will find some guidance on completing this section. If we go to page 18, we will see the chart. We are more familiar with this chart by now, and it has each of the variables contained in section 6. As this section does not have thresholds, the number of steps in this chart are only 2. Step 1 provides some guidance on evaluating each variable, and step 2 there's some guidance on how to record it. The next one. So we will now review the last section of the labor care guide, that is section 7, shared decision making. And let me clarify first that after reviewing this section, we will go through a clinical case showing how to complete both section 6 and section 7. So this section is directly related to the following recommendations for intrapartum care. It's related to the recommendation on respectful maternity care. I know you are all very familiar with this concept and definition, but we will just review it quickly. This refers to care that is organized for and provided to all women in a manner that maintains their dignity, privacy, and confidentiality, that ensures freedom from harm and mistreatment, and enables informed choices. This is something important for us. This enables informed choices and continuous support during labor and childbirth. And then we have another recommendation that is effective communication between maternity care providers and women in labor and also their companions, using simple and culturally acceptable methods is recommended. The next one. So section 7, shared decision making, aims to facilitate the communication between woman and her companion and the healthcare team, and also the consistent recording of all the assessments and the plan that we, the healthcare providers, agree with the woman and her companion. Who recommends effective communication between maternity healthcare providers and women in labor, including the use to make it effective, we need to use simple and culturally appropriate language. Ideally, we will provide clear explanations of the procedures and their purpose to each woman, and the findings of physical examination should be explained to the woman and her companion, and the subsequent course of action should be clear to enable a shared decision making. In this section, we mainly have two variables, that is assessment and plan, and we'll describe a little bit more what is expected to record here. The next one. So we can have guidance on completing section 7 in page 21 in the user manual. And actually, you know, the first few times that I completed, that we complete the LCT, probably we will need to check the manual several times. After a while, this won't be needed. But just remember that this is could be a useful resource for you, mainly at the time you start using the LCT. So here in the assessment, we will record an overall assessment. For example, normal progress or slow progress of labor or fetal distress or whatever is appropriate for that clinical case. Or any additional finding that we couldn't document among the other parameters that we were recording, and that we really want to highlight because it's important for labor monitoring. Then, as for the plan, depending on each clinical case, we might consider one of these examples. For example, for normal progress, we might record continuation of routine monitoring, or we can describe the prescription of any diagnostic test if needed. We can record augmentation of labor if we have diagnosed as slow progress of labor. We can describe specific procedures such as artificial rupture of membranes, assisted birth, either with vacuum or forceps, or a cesarean section. These are just a few examples. You know, of course, there are more plans that we can record here. But take into consideration that women and her companion should be involved in discussions and be allowed to make informed decisions. Each time a clinical assessment of the woman and the baby's well-being is completed, we will record the plan based on that shared decision, even when we have normal progress. So we are expecting to complete a plan always. If there's something abnormal and we need to intervene in the course of that labor, the progress of that labor, or even if everything is completely normal and we are just saying we will continue with routine monitoring, but this is also a communication tool. So even when everything's normal, we will record a plan in this section. I will pass it to Rose now. Rose, can you hear?
Veronica, I think that she was having some technical difficulties with poor connection. Do you want me to read the example for her? Yeah, I do that.
I have
And then, okay. We can hear you, Rose.
Had normal progress of labor and childbirth. Sorry, can you hear me?
The bishop can go close to the mic.
Sorry, okay. Mary Jane had normal progress of labor and childbirth. During labor. Oh, can you hear me now?
Yes, yes.
Thank you. Mary Jane had normal progress of labor and childbirth. During labor, Mary was encouraged to walk and to have a companion of her choice present. The clinical parameters remained within normal thresholds. Consequently, additional interventions were not required. Next slide. Next slide, please. Yeah. So, in our labor care guide, we see Mary Jane having normal progress of labor, but still recorded under assessment.
I think we have lost Rose again. Maybe Mercedes, you could take over, Vero.
Yes, let me do it because she's having difficulties. Okay, so let me start again with this slide. So this is for the last section, medication and shared decision making. So what we say is that Mary Jane had normal progress of labor and childbirth. During labor, she was encouraged to walk and to have a companion of her choice present with her throughout labor and childbirth. And all the clinical parameters remain within normal thresholds. Consequently, no additional interventions were required. So as you can see here in the plan, and if you remember a little bit of the story that we are telling about Mary Jane, so based on the assessments, there was no need, for example, to provide oxytocin. So here you can record no across or other medicines, including IV fluids. And this is for the active first stage of labor or during her second stage. If you remember at the beginning, and I think that this is coming from the example we use in the part 1 of the webinar, but she was in pain and requested pain relief, and her companion was providing her with some non-pharmacological pain relief. I think that it was massage or so this was recorded as an assessment. So she needed pain relief, and as a planned, then she was offered companionships and relaxation techniques to manage her pain. As you continue to monitor her, all the parameters were normal, so you can record that she was having normal progress. So, and this is important because there's not only when there's a problem or complication that is identified that you have to record your assessments and do a plan, but also when things are progressing well. So if there's nothing abnormal or further action is required outside your routine monitoring, then you can also record your plan here as shown here. And it is the case for the active first stage of labor, but also during the second stage of labor. Another thing that includes the LCG is that the person who is responsible for taking those observations and recording them in the LCG can put her initials here. So you can know who, for example, was taking care of her and who continues to do it, for example, if there was a change in the shifts, for example, or need to change the provider for any other reason. So this is how a completed LCG looks like. And Vero, I don't know if you want to take over from here or you want me to continue.
No, I can take over.
Okay.
So we merely added this slide to show you, because we went section by section, and that was merely to try to explain each section in detail. But this is how it looks, you know, once we complete an assessment. For example, the first assessment, that is the first column that we completed, you can see that we recorded all the practices related to supportive care, baby, mother, labor progress, medication. And then at the end, after completing all those, all the assessment, we will record the assessment and the plan. And at the very bottom, we can see that we can record the initials here at the bottom. So because this is a tool that we will use with some other healthcare providers. So it's also, we insist on this, a communication tool among all the healthcare providers. You will have this in the manual and in the presentation, and you will see in details if you want later. We have one final question for you if you want to vote, so that we practice. You know, it doesn't matter if the answer is correct or not. We are just trying to practice and to clarify. So get ready to vote. And the question is, a plan should be registered in the LCG only when there's relevant information to be highlighted. Is that yes or no? Which is the correct, the right answer? So we will give only 60 seconds, but mainly because we don't want to prolong the webinar too long. But we are very happy to see that we have more than 100 participants voting. And actually, you know, this information is so useful to be able to clarify when we first, our first contact with the LCG could be confusing. So
There are 2 yes in the poll.
Sam, could we have a no option in the poll?
Yes.
We are not sure which of the yeses is the no.
Yes. So the first option should be a yes and the second one should be a no. Can we fix it?
Yes, 1 second.
Thank you. Give us 1 second. We will read the question again just to review it while we fix the response options. So we are asking, a plan should be registered in the labor care guide only when there's relevant information to be highlighted. We will start voting again very soon. In the meanwhile, you can think of the questions that you want to discuss with us and post it in the chat box. Now we are ready to vote again.
Yeah, sorry about that.
Yeah, that's fine. Thank you. Oh, wow. We have so many people voting. Thank you. That's great. We will give a few seconds more to complete the voting. We will show the results and explain a little bit what would be the best option in this case. Okay, we are closing the last 5 seconds. Last time to vote, and now we are ending the polling. Let's share the results. So a plan should be registered in the LCG only when there's relevant information to be highlighted. And actually the right question would be option 2, that is no, because each time we make a clinical assessment of the woman and the baby's well-being, each time we complete that assessment, a plan should be recorded in the shared decision-making section. If all parameters are normal, then the plan would probably be, as we mentioned before, continuation of routine monitoring. But remember that this section could also facilitate the communication among healthcare providers. So it's, it will generate a cycle where we plan and then we continue the monitoring and start again with a new assessment after a certain period of time. But it's also, if we are working with some other professionals, it will help them to know what was our assessment and our plan during the previous period. So it's no, because we are not planning to record a plan only if there's relevant information, only if we found abnormal observation. Ideally, we will record the plan, we will register the plan in the LCG every time we complete the assessment, regardless of the progress of labor, if it was normal or it was not normal, if the observations were all normal or abnormal. We are expecting that we always record what was our plan. Okay, so thank you for participating. It was so informative for us. And I think we can proceed with the following session.
Okay, so Fatima, please go ahead with for the session on question and clarification. I'm sure you have questions in the chat box.
A lot, and they're pouring in minute by minute, or I should say second by second. So thank you so much, wonderful facilitators, for taking us through this great resource. And our participants are very keen to know many things. And let me start with the first question, which is, I've lumped them together. It's about 4 centimeter and 5 centimeter. So I would request if Veronica or Mercedes, if you could reinforce the message which you have given already during the presentation, but our colleagues would like to know that so there are many questions linked to this, just 4 cm and 5 cm. And they also want to know they want to know the reason, the justification for moving from 4 cm to 5 cm. And then and they're asking, like, if active phase of labor start at 4 centimeter of dilatation for both parity, multi and primigravida, and then yeah, they just want to know the reassurances that's the way to go now. And so that's one thing. Some of our colleagues also went through another WCA course where they found out it's written 6 cm. So why there's a difference? One of our colleagues is asking about it. So let's a big chunk of questions are linked to 4 cm and 5 cm. And yeah, then I'll move to other questions if one of you could answer that one.
Sorry, I was trying to find my mic. Sure, I can take this one. So yes, the definition from WHO of active first stage of labor is starting at 5 centimeters. And that's a change from the previous definitions that was starting at 4. So, and this is based on a systematic review that was used to develop that recommendation. And there has been also an update of that review that we published last year. I will be sharing, as I mentioned it before, with you the links to those manuscripts, so you can look at them. But basically, what we look at is at studies that were reporting how women move from 1 centimeter to the other across labor. Most of them reported starting at 2, 3, or 4, or beyond. And what we observe is that when you look at that evidence, it is from 5 centimeters that labor seems to really accelerate for most of the women. And the way we look at the evidence is that we only selected studies where women at the end had good outcomes. So there were no labor complications and no stillbirths and or other bad outcomes for them. And this, we did it so to be sure that their recommendations were not increasing risk for women in that sense. And the findings of that systematic review is actually, I just wanted to go back to, I think that here you can see it better. The findings of the review is actually what is reflected here. So these times here are based on that systematic review, and they reflect the longest period of time women could stay, for example, at 5 centimeters or at 6 centimeters, 7 centimeters, having still good perinatal outcomes at the end. And what also clearly shows is that that previous idea that we have, that labor was progressing as 1 centimeter per hour, and that progression was the same from 1 centimeter to the other, might not be true. And that's why we change the definition, and we also change the parameters here, as the other and action lines that we were used to use seem not to be, or are not longer valid. And in that sense, just because I also saw some questions around that, we did another systematic review looking at how well the other action lines detected women who will end up having labor complications or bad outcomes. And what we found is that it wasn't really something that could help you in identifying those women earlier. And even women who were having not crossing, for example, ALER or action line may also present with bad outcomes. So that's evidence that we use for another recommendation that is in that document, and that also underpinned all the changes that we introduced in the LCG. I hope that that clarifies some of the remaining questions still. And as soon as I stop sharing, I will put those links in the chat box.
Thank you. Thank you, Mercedes. And as most of our colleagues are really appreciating the session, that it's very informative, very educative, and I'm so happy to see all these questions, because this shows their keen interest. So now the other set of questions are linked to Miss Mary Jane's example. And here some of our colleagues are asking, so I'll just read the question, and if Veronica, you and Rose can write them down and can address however way you want. So question one colleague is asking about, in the Mary Jane example, the fetal presentation was transfers at some point with meconium stained Laisser. Why is that considered normal? That's one. Then second question is on how are we going to document delivery on the labor chart for Mary Jane to show she has really delivered? And then one question is, now that Mrs. Jane had meconium plus no action. Sorry, I didn't get it properly, but how to document it, basically the question is around it. And some of our colleagues are asking if you could elaborate on the documentation part of second phase. And there's another last practical question from one of our colleagues, is saying, I heard in active phase contraction should be checked every 5 minutes. This is the second phase of second phase. But in this phase, clients are normally irritated, and checking questions every 5 minutes will be a challenge, since most part of the health facilities uses the old method. What can be done, please? So if you could answer these lot of questions, and then I will ask the third and last one. Over to you.
Thank you. I can start, but please feel free to add your comments, Rose, that you are an expert in the yeah. case. It's just because of the connection, but I will start with some explanations, and probably Rose can add to what we are explaining. So yeah. First, the transverse position is not considered normal. So actually, if you see the second column, the second column of the LCT, I know it's small and a little crowded, but in the section baby, we have fetal position. Then we have the second column, they are perfect. And we have two thresholds. That is P for posterior and T for transverse.
Yeah.
So look how we completed this. We completed, okay, first it was a posterior position, then it was a transverse position. And actually, these observations met these criteria in the alert column. So we highlight it with a circle because we don't consider that this is completely normal. And this requires special follow-up. Yes, so conversely, the last assessment, it was an anterior position, is not highlighted, is not circled, and this is considered normal. So I hope that answered the question. We have the same concept. Then, Rose, do you want to add something, please?
No, I concur with you. This is not normal, as you have said. Maybe I didn't see the example because of the internet, but this was not normal. It's not normal labor.
Okay, good.
Yeah. Yeah,
So
even meconium stage is known. It's not normal. Maybe the one who asked the question may check again where it is cycled and.
Yeah, maybe the colleague who asked this question also was saying that she was unable to see the screen properly. That might be the case because everything was so small.
It's very small.
Yes, so it's difficult to visualize. Yeah.
Then as for the meconium stain fluid, so we go back to the same section, to the baby section, and there we have in the first column amniotic fluid, that is the parameter, and we have two thresholds, two alert values. Then that one would be thick meconium, that is an M with 3 crosses, and then a V for bloody stain amniotic fluid. So that would be what it has really to trigger in some specific actions. Probably if we have, only one cross of meconium, we will follow this up, but it won't require a more aggressive intervention. So if we go to the manual, I don't know if we have the chart for amniotic fluid. I think if you go back, Merce, to the chart from the user manual, there, baby. Okay, here in amniotic fluid, you can see that in step 3, where we say check the threshold, the alert is M and 3 crosses. That would be thick meconium, or B, that is blood. The other probably require, we will continue monitoring that, but it might not require an intervention. Nevertheless, this will depend on each clinical case. This will depend if we have a normal fetal heart rate, if we have these accelerations or not, maternal status. We will try to assess each individual parameter, but the decision that we make, it will be based on the overall assessment. So this is what is considered the alert. When all the rest of the parameters are completely normal. Otherwise, we will probably make a different decision. So this is only a suggestion, and we insisted on this on the previous webinar. These are suggestions, but it shouldn't replace your clinical judgment. That is always more important for you to make decisions, because you have a real case in front of you, that each case could be completely different. So it's very difficult to represent all these possible scenarios in one chart. So this is only a suggestion, and the decisions should be made mainly on your clinical judgment. And then there was a question about the contractions every 5 minutes. And Mercy might be able to add some information about this, but there's a lot of variation across the world on how frequently monitor the uterine activity during the second stage, even during the first stage. And
Yeah.
so
Can I
this,
comment?
yes, of course, Rose.
Yes. From experience, when a woman is in the second stage of labor, definitely it doesn't take generalize all women. Individually, we all know that women can take a little bit longer also. So within that situation, a threshold of 5 minutes, every 5 minutes is given. And if the woman you cannot check every 5 minutes, then the woman is just about to deliver. It won't be a problem when people use labor care guide. Try 5 minutes and they will find you may even check maybe twice or thrice or once at least, and then the woman is delivered in normal labor. I think putting more than 5 minutes will be unrealistic. So the standard of 5 minutes is given there and looking at individual women's stages. Yeah, that's my comment.
Thank you, colleagues. It's like more than 100 right now questions in the chat box in a Q&A section. I don't think so we will be able to answer all of them, but we definitely need to have a session where we maybe for each area a separate session, something we need to think with Mona and Nancy how to do it and with our facilitators later. But maybe just to I know we have just half an hour, and a lot of questions will also be addressed by the Partograph comparison, which is our last bit of this part 2. There are a few interesting questions which I would like to ask before we jump onto the other session. But trust me, we would not be able to answer all the questions which are out there, but it's so enriching. We'll definitely look for ways how to convey these answers to all our participants. So there's one question which I found really interesting. So one of our participants is asking, so does this change the finger representation during vaginal examination? You know, for each finger, one finger equals to 1 or 2 cm. That's one. Then one of our colleague is asking, the old Partograph had served 2 main objectives: monitor prolonged labor to prevent it, and to prompt the clinician to act promptly, which is why we had action and alert lines. And there are a few other questions linked to it because we don't see now those 2 lines anymore. So she's saying we seem to have lost that now. What's the benefit of using this labor care guide compared to the usual documentation in the nurses and doctors' notes? And then our other colleague is asking, are we to totally stop the use of oxytocin during delivery? And then one of our colleagues is asking, she couldn't find any section for newborn, EBGA score and other things. So let me, okay, last one. This is last one. One of our colleagues is asking, does that mean if women admitted at 5 cm and stay for 5 hours, still okay unless it reach 6 hours or more? We do not need to act as far as the woman and fetal condition is okay. Let me stop here. Yes, over to you.
Do you want me to take those questions? I will try to answer them quickly, and then if you agree, I can continue with the last set of slides. Would that be okay?
I think so, and then we can combine some of the questions also later. Mona will ask.
Yeah. And then one thing that we have started preparing, and we have certainly used all the questions that you asked last time, and we have to add the new ones, is a Q&A kind of document. And if you give us some time, we can work on that. And that's something that we could share with also. We make sure that most of the questions are also answered in written. So the first question, there's no changes in the way you will perform your vaginal examination. There's no changes in that sense. So the 5 centimeters would be still the 5 centimeters anyway. So I hope that that answers that question. Yes, correct. So if you assess her at 5 centimeters, she can remain at 5 centimeters up to 6 hours, and that will be considered normal. Of course, you have to look at the other parameters, right? And see if something requires action or is abnormal in that sense. But otherwise, if everything is normal, then you can be reassured that that woman will continue progressing and that there's no still delay in labor progression for her. Regarding the alerts, one of the aims that, or the ideas that we had behind removing alert and action line, that is not only that evidence that is telling us they are not useful to detect women who might have bad outcomes at the end of their labor, is also that there's a need also to look at other parameters that you are monitoring throughout labor. She can be doing well for labor progression, but the baby may have having problems. She may have presenting with problems. So in fact, we really think that this tool adds on, because you still have alerts for the labor progression. It's not aligned, because we know that that 1 centimeter per hour is not valid based on all the evidence that we were able to gather, but you have limits here on time. So you can act upon if she is moving slow. But you can also highlight and see other things that are happening to her. And then you can also take action, even if labor is progressing well, but the baby or the woman herself is presenting with other complications. So be reassured, you have those alerts there. And those principles of the Partograph of allowing providers to identify deviations from normality early are still there and are expanded for other clinical parameters, and also for you to provide the supportive care. The use of interventions, including oxytocin, has to be reserved to those women who really need it. So by allowing her to progress normally, for example, oxytocin might not be needed. So that's what we wanted to stress in the presentation. It's not that you don't have to provide it. If it's required, you can use it. You can use other medications. That's not an issue. And then last one was about the newborn. And just as a reminder, the WHO modified Partograph didn't include a section on newborn. I know that there were a lot of adaptations, and that in some countries you have a section or an additional page where you can also record some key information around third stage, but these are seen more as country adaptations, and probably they also address other issues around not being able, for example, to record all that information in the medical records. So for us, we wanted to keep this to fit in one page, and all the information that comes from your monitoring during latent phase and third stage and the baby, they can go in the medical records. So let me just continue and try to keep us on time. We felt that we needed to go with you through what are the differences between LCG and the modified Partograph. So what I will be highlighting here are similarities, so things that have not changed or not changed in their principles. There might be a slight changes in the content, but again, and as I just mentioned it, there's opportunity for you to adapt this tool and make it more appropriate for your setting. So the first section that allows you to identify the woman and characteristics of labor are present in both tools. Same thing for sections to that allow you to record monitoring around babies and women well-being. So fetal heart rate, amniotic fluid, the fetal position, vital signs of the woman are also here. As you can see, the main difference is that in the LCG, you have to actually plot the actual numbers, and you don't have to go and try to look for the correct line and put your recordings there, but is the same thing. Medications is exactly the same. And then you have a section where you can plot against time your labor progress. And this is what we have been extensively discussing today. And I will just highlight those things to you once again. So both tools have a section where you can record labor progression and with alerts that allow you to take action early, but they look a bit different. The first difference is that LCG, you start at 5 centimeters, and this is based on the new WHO definition for active phase stage, first stage of labor, compared to 4 centimeters in the WHO modified partograms. We extensively discussed this, but the evidence-based time limits that we have here are to move from 1 centimeter to the other. Is different from that fixed rate of 1 centimeter per hour that were depicted in the alert action line. And the reason behind that is that this might be too fast for some women, and also because it's inaccurate in allowing you to identify women who are at risk. You can also record duration and frequency of uterine contractions, and you will put here the actual values in contrast with how this was done in the Partograph, where you had this more graphical representation of the uterine contractions, including the strength, which are no longer recorded in the LCG. And the main reason is that it is more an objective measure and probably not that useful in terms of monitoring contractions. Other differences, there's new sections. So a section on supportive care, a section that allows you to record summarize your assessments and your plans, and a section for recording second stage of labor, not only in terms of progression, but also all the other clinical and non-clinical parameters and your plan during second stage of labor. So you can explicitly record supportive care. You will be required to record the actual values that you find and not in a graphical way. You also have this alert line that tells you when you have to highlight deviations from normality, and you can also plan for actions either to correct that deviation or to address the complication, and monitoring and recording your findings throughout the second stage of labor. In terms of additional resources that you have, and you will receive the links with the presentations, but the user manual you already have, I hope, and this what has been shared during this webinar. The WHO recommendations, we are referring over and over again to them. I invite you to consult the document. It may look a bit long, but there's a lot of explanations, especially around the definitions and the duration of labor that you can find there. And there's 2 slide docs that we have prepared and are available online, summarizing the recommendations and the LCG user manual. Then in terms of more guidance for your clinical practice, we have 2 handbooks. So one that covers management of childbirth and labor for normal labor, and then another one that refers to the management of complications. And we are also sharing with you some additional resources on how we took the process to develop the LCG, and we published the results of the pilot study that we conducted in 6 countries, and where Veronica and Rose had a leading role in this study. And there's some additional publications that will soon come out in terms of the development of the LCG, and a commentary that will be soon published that explain you the why of the LCG. So in summary, this is a new tool that we developed to facilitate implementation of the intrapartum care recommendations and to help you to provide women with high quality, respectful care during labor and childbirth. There's a set of educational dissemination materials that we have developed, and these are those that I just presented, and we really invite you to consult those. And we hope that you enjoyed this webinar and that you learned a lot. We know that there's still a lot of questions, and as the tool will be introduced in countries, more questions will come. We will try to answer some of the questions around implementation, introducing LCG in countries, and sharing more of the experience from other midwives that already use the LCG in our pilot study on the next webinar. And I'm sure that Triphonie will let you more about that to close. So thanks a lot. And if there's any remaining questions and we have time, we are here and happy to respond to that. Thank you.
Thank you very much, Mercedes. I think, as you said, we do have some 20 minutes for the remaining questions. So colleague, feel free to ask the most burning question so that you go with concrete answers. So Muna is going to lead us through this session of question and clarification. Over to you, Muna.
Thank you, Triphonie, and good afternoon, colleagues. So I see many questions related to operationalization of this new LCG. When is it going to be started at the country level and at the facility level? The guidance around, in terms of regulation, which authority should we wait to go ahead with this implementation? So these are the implementation questions. A lot of questions around scientific evidence for all these changes, but as Veronica mentioned, it's part of the tools and the available materials as a reference, but participants wanted to know evidence around the changes that have been made in the LCG. And then on Partograph, in the comparison of the new LCG and the previous Partograph, a question says, please, do we have to join the cervical dilatations, then the descent after delivery as we used to do on the former Partograph? Veronica or Rose, or over to you. Or shall I repeat the question?
No, that's fine.
Okay.
So I will start with the last one. That is the most, is related really on how to complete. So yes, in the labor care guide, we are recording the cervical dilatation with an X. And it's, the third variable that we will record in the LCG in section 5. And then separately, we are recording the fetal descent with an O. So in this case, these two variables are plotted separately. Then about the scientific evidence, so, it's quite extensive and there are a lot of details within the WHO recommendations published in 2018. So it will be probably very useful if you can review that document. You will see that it's cited several times throughout our presentations to make it easy for you to access to that document. And probably most of the questions related to the supporting evidence will be answered by reviewing that document. And then, yes, Rose.
In addition, there are articles about Partograph, which were showing how people are dissatisfied, and these, they will access TINA's and WHO articles on Partograph, and that drive the scientists to look at the best way to record women's delivery normal progress and labor progress. So in the initial issues of evaluating Partograph, there are a lot of studies which showed dissatisfaction and difficulties in filling. And then with what you have been saying, the recommendation, WHO recommendation, those two drive the people to develop the LCG with certain evidence. And I'm sure most of the people have been struggling since the Partograph started. There were a lot of changes because there were difficulties in practicalities, and yet there was a need to monitor women with the standard tools. That's over to you.
Yes, and then we have this last concern that is about when we start using how we introduce the labor care guide in clinical settings in our labor ward. And that's, of course, very interesting. And we have some experience coming from a pilot testing that was conducted in 6 countries, in 12 hospitals. So you will see at the end of the user manual that we have 2 sections that will help you or give some guidance, some ideas on how to implement the LCT in clinical settings. And also, that will be the main topic on our next webinar. We will have a panel of experts that have already used the labor care guide, that participated in this research study, and they are willing to share their experiences and lessons learned with you. So probably that session, if you have that question, try not to miss the next webinar.
Yes, thank you, Veronica and Rose. And please, next webinar is coming also focusing on this operationalization. Don't miss it. Stay with us until we finish this labor care guideline. Another question is, Veronica and Rose, after dilatation was found 5 centimeter, when is the next vaginal examination? Does the normal 2 hours change?
I think Veronica presented about half an hour checking of cervical, of vaginal examination, and then there people will see what to pilot according to the alert line, how it shows. If you could check the WHO care guide now, and people can see the alert line showing cervical plotting of X when it is 9 centimeter, and the hour 8 centimeter, and the hour 7, and the hour. So to me, I just want to say, if people can practice, then most of their questions will be cleared.
Okay, that's a very good advice, Rose. Once we start practicing, also this a lot of our questions will be clear. A lot of appreciation, a really helpful presentation, and people are really excited to introduce this labor care guideline in their setting. And maybe one question to ask is, there is a participant who looked at page 5 of the manual and says labor takes longer than 12 hours. If the labor takes longer than 12 hours, a new LCG should be opened and monitoring continue. My question then is, why the alert reference on the duration on dilatation? Will it be okay opening a second LCG?
Yes.
Vero, go ahead.
Okay.
You can respond that. No, you know the response.
Okay. Let's see. So, yes, if the labor exists that time, of course, you won't have space to continue recording what you are monitoring. So it's recommended to open to have a second page of the LCT. But the recommendation, you are completely right, and it's a very good question. The recommendation is saying that for the first labor, on average, it won't take longer than 12 hours. But we all know that sometimes, this would be less frequent, but it could take a little longer. And so in that case is when you will need a second LCT to continue recording all your observations and your assessments. The recommendation speaks mainly on the average duration of labor, and the other is more like a practicality related to be able to continue recording. What we consider normal or abnormal, we will have some thresholds to try to guide us when to intervene. But once again, and this is a very important message for you, it will depend on the overall assessment. So, the recommendations and the guidance that we give in the user manual are mainly based on the scenario where all the rest of the parameters are completely normal. That not always happens. So you will probably have to make decisions and discuss this with the woman. depending on the rest of observations and on the overall assessment. But it's not impossible to continue monitoring a woman beyond the 12 hours if all the rest of the parameters are completely normal. And in that case, you will need to start a new labor care guide.
Thank you. Thank you so much. It's not a question, but a suggestion is also about more on newborns as well. They feel that the newborn part is missing from this session in terms of using LCG. That's a suggestion. There are many more questions, but how are we on the timing? Should we continue asking?
I think maybe do one more round and then we round up because of time.
Okay, there are questions related with pain medication. Maybe if we can pick a question from there. So when can you say it's clinically appropriate to give pain medication during labor? And if you can give us example. And what is a recommended pain medication during labor for pain relief? And for pain relief in active first and second stage of labor, the recommended medication for pain during active first and second stage of labor. Over to you.
Sure. So if you look at our guideline, you will see that there's several recommendations on different pharmacological, non-pharmacological methods that you can offer to women. So, and that are effective and safe. So these include epidural, analgesia, parenteral opioids, and for the non-pharmacological, relaxation, breathing, manual techniques as massage, for example, or warm packs. So all of these are effective in relieving pain. The use of them would depend on mainly on the woman, right? And whether the strength of the pain she's feeling and also her preferences. So here, all the things that we have been also stressing on using the LCG and the decision-making, shared decision-making, I wanted to say, are key when it comes to managing labor. I don't think that there's a clinical indication to use one or the other, and they can be used in combination for sure, always in consulting the woman and following also her preferences. Of course, then you will also have to consider the resources that you have and which of these methods are also feasible and available in your hospitals to be provided in a safe manner. And here, of course, I refer mainly to the pharmacological methods, epidural or opioids.
Okay, thank you so much for those clarifications. I will hand over now to Nancy.
Okay, Triphonie, can I go ahead?
Please.
Okay, I just want to share now the next steps that we are going to have following this very, very interesting series that we have been privileged to be part of. like we have said, this is a series of 3 webinars, and the last part of this webinar will be on 25th March. At the same time, please make sure you're there. As you've heard from the panelists, this is the time when we will be going through how to actually introduce and operationalize the labor care guide in your health facility and at national level. And we will have people who have actually used this tool to share their experiences and how they found the tool, so that we also learn from them and see how to move forward. We have also organized through the WCA platform to have this training on the WHO Labor Care Guide available on virtual learning platform. And this will go live, I think, in about a week or so. The WCA team will send out an alert once this training is live. And so you can take it at your pace and get all the detail. We have also shared a link in the chat to all the presentations and the materials. And if you remember from the presentation of Mercedes at the end, there are all the links to all the important documents, including this presentation as well, that you will find. And we encourage you to go through them so that you really understand the basis for the labor care guide and the instructions on how to complete it and how you can use it. In terms of country uptake, there is usually a process. We can say confidently, WHO, UNICEF, and UNFPA, we are ready to provide technical support for countries to take up this too. So the usual process is that the Ministry of Health needs to send the request to the WHO representative, and then they can escalate this request, and we can organize all the technical support that you need to adapt the intrapartum care recommendations and the labor care guide, and orient you on how to scale up and operationalize this very important tool. For those who are from French-speaking countries and who are wondering what we are planning, we do plan to have session for the Francophone countries, and we will be able to let you know when these sessions will be, so that the French-speaking countries can be able to also benefit. And during that session, we will try and have simultaneous translation into Portuguese, so that the Lusophone countries can also benefit from this training. These are some important links, just to remind you of them, but like we said, the links to key documents that will be very helpful for you are going to be available at the end of the presentation, and they are also available in the link that has been posted in the chat. Please access these documents and look at them and familiarize yourself with the basis for the recommendation. However, we are still available to answer any questions. You can send on email, or you can use the different networks, and we will organize how to respond to your question. So don't forget that on 25th of March, same day, we are going to have the last session of this webinar, where we will be discussing how to operationalize and roll out the labor care guide in your health facilities. Thank you, and over to you, Triphonie.
Thank you very much, Nancy. Thank you very much, all the facilitators. And thank you very much, all the participants. Really, it was impressive. We have had more than 840 participants, and almost the all stayed along the session. This is really a very good sign of your commitment. So from my recollection, I could hear that this new Partograph is for all women, regardless of parity, membrane status, risk, and it is for all levels of care in health facilities, and it will really help us to reduce the unnecessary interventions, and it will probably have less stress for the mother and from the healthcare provider. It's being very, very practical. It is more informative, and we have shared with you all the new source of evidence, so that you can, if you have time to really look at those materials, and then it will be easier to implement this new Partograph together with the intrapartum care recommendations. So really, thank you very much. We all have the same goal, that is, no woman should die while giving birth. So it's really a pleasure to see this kind of commitment. Thank you very much, all the facilitators, all the participants. As we say now, we are all together in this. Stay safe, stay saving women's and newborn lives. Thank you very much, and see you on, I think, in March, 25th of March. Thank you very much.
Thank you.
And have a nice day.
Yeah, thank you, everyone. Bye.
Thank you, everyone.
Thanks all. Bye.
Have a nice day.
Goodbye.
Thank you very much. Bye.
Thank you. Bye, everyone.
Bye.
I will be closing the webinar now. Thank you all to all the participants.
Thank you, Sam.
No worries. Have a great day, everyone.
Yeah.
Thank you.
See you on the 25th of March.
Yeah.
Thank you, Sam.
Yeah.
That was brilliant.
Yeah.
Thank you.
Thank
Bye,
you.
Sam.
Bye.
Thanks.
Thank you.